All right, good morning. This is Senate Health and Welfare. It is Thursday, February 8th, and it's really quite a beautiful day outside. Now, that's where we should be meeting, right? But we're not. We're here. But there's a little sun in here, too. So this morning, we're going to look at some of the bills that we have been working on. We're also going to look at a new bill for us, which is 302 on the Alzheimer's issue a bit later. So first up, though, is S-173, and we have been through that with Jen. It's the data privacy, collection and sharing and selling of consumer health data, and Mike Fisher is here to testify from the health advocate perspective, which will be very important for us. And let me just say something. Yeah, please come on up. To say something about S-173. So as we know, the House has a comprehensive data privacy bill that they're looking at in Commerce. And they've somehow picked up the language from this bill, and it's in that bill, and they're modifying it there. So ultimately, we're going to be looking at that language, whether it's here or whether it comes over from the House. And my understanding of the House bill is it's on a fast track. And I just will share with you that S-173 was actually one of my priorities. And the reason it is one of my priorities, several reasons, but one of which is that I was invited to visit with some of the members of the executive branch in Washington, D.C. regarding reproductive health protections. And the data privacy bill was one that I talked with about 20 or about 25 other senators and representatives from across the country. And I shared with them some of the work that we've done, and they shared with me some of the work that they've done. And one of the states that was there was Washington State. The bill that we have in front of us, as we know, is modeled after Washington State. And I brought my interest home from Washington to this bill and asked Jen to put it together, but she's done a great job, as usual, doing. So this bill is important to me, and it's unfortunate, I think, that we may not really have the opportunity to follow through with a single bill in this committee, but we will be able to look at the bill collectively as a committee once that language comes over from the House. But I did want to share with you that there was a lot of work behind the bill prior to its introduction, as there usually is when we each introduce our bills. We welcome your testimony on it, and this will be probably the first of a couple times that we hear from you on the bill. So thanks for being here.
Thank you. Good to be here. Mike Fisher, healthcare advocate. Let me start by saying Representative Senator Williams and I were talking this morning about the fire hose feeling of the session at this point, and so I just want to recognize that if you have any in-depth questions about what I have to say, I'm going to have to say that's a really good question to get back to you. Another member of my team, Eric Schulteis, is the point person on data considerations and unavailable today, and so I'm pinch hitting. I wonder whether, given what you just said, that we're expecting a bill to come over from the House, it is my understanding that that Vital was going to provide an amendment to exempt the HIE. And I don't know whether that's happened, whether we've seen an amendment here or on the House side.
No, we haven't seen it yet.
But the Healthcare Advocates Office wanted to step up to the plate and say we support that concept. We support the bill, by the way. We support the bill. We support the effort.
That's a good place to start.
It's a good place to start. And we also, there's a long history about consumers' rights around healthcare information in the HIE, and I won't go through all of that, but just to recognize that Vermonters have an opportunity to opt out of data sharing in the HIE. And so, given that, that protection and given sort of what the HIE is, its purpose, we thought it made sense to support that notion of exempting the HIE, the vital from the protections of this bill. And, but of course, we need to see the language. I'm here to say we support the concept of that. Need to look at the language when it actually lands to see whether it does what we want it to.
Any questions? So the expert in your office is,
Eric Schulteis,
okay,
and he's unavailable today, but we will continue to track this and continue to.
no, we'll have him in, and it's not that we're leaving the bill alone. We'll continue to take some testimony, and especially when and if that bill comes over, that'll be it. We'll continue to work on this bill and see what happens with it.
And I'll just say, you might notice that I'm sort of making this little effort to broaden the face of the HCA. You had Sam in here, Sam Peisch a couple of weeks ago on the doula bill. You have Charles Becker
Right.
in a minute, and we have a great team, and
Good.
so we'll bring them to the table.
Thank you. Questions for our healthcare advocate?
Thank you.
Okay, thank you. So we'll move right along. We're going to leave, and we're a few minutes early. We're going to leave 173 for obvious reasons, and move on to S98, which is the Green Mountain Care Board Authority over Prescription Drug Costs, and Charles Becker is here. So we haven't had you in before, but we did.
Very briefly the other day. Thank you so much, Joe.
And so it's good to have you at a time when you can present more information.
Yeah, well, thank you for having me back. I really appreciate it.
And do we have your stuff, your testimony?
I will submit it after the.
Okay, so you're going to go through it up on the screen?
I am, yes.
Yep,
Yep.
that's fine.
Okay, all right. Let's see if I can actually get it to present. There we go. Is it up there? Yes, all right. So, thank you again for having me back. I really appreciate it. For the record, I'm Charles Becker. I'm a staff attorney with the Office of the Healthcare Advocate. I titled my presentation Copay Accumulator Adjustment Programs, but I'm here to testify about S98. And so it occurred to me I should make that connection to S98 up front instead of bearing it in the middle as I had done originally. So that's what I'm going to do. I reorganized my presentation and I'm going to testify about S98 from a consumer advocate's perspective and also from the perspective of a person with high annual pharmacy claims, and that's me, okay? So that's the perspective I'm bringing to this presentation.
Good.
All right, so on this next slide, we have a snapshot of what I think most of us here would consider to be a problem in need of a solution, right? So the United States has very high drug prices. We pay more for pharmaceuticals than most other countries in the world, if not every other country in the world. I'm not here to explain why we have really high drug prices, but I will say that at least a part of the reason is that we have a system based on hidden discounts and rebates that incentivizes high list prices. If you want a bigger rebate, you want a higher list price, right? So 50% rebate on $100 is $50, but a 50% rebate on $1,000 is $500. So there's a system here that incentivizes higher list prices. How do we solve this problem of high drug prices? Well, that's partially, what S98 is attempting to do. It's a policy solution to give the Green Mountain Care Board the authority to do affordability reviews and potentially set upper payment limits. That's one idea. My boss said last week, Mike Fisher said last week, the HCA supports giving the Green Mountain Care Board that authority and giving this a try. But until we solve the problem of high drug prices, what do patients do about these prices right now, right? So there are people right now with very expensive to treat chronic conditions that need access to medications now. And they're facing, particularly right now in January, in their deductible phase of the year, right, these high list prices when they go to the pharmacy counter. So what many of these people are doing is they're turning to, we've heard them referred to as drug coupons. I'm using here the phrasing drug manufacturer copay assistance. I think there's an important distinction there, and I'm going to explain why. So copay assistance is, so what's happening here is that when a person presents one of these cards at the pharmacy counter, the drug manufacturer is actually paying money on the patient's behalf to the pharmacy to pay for that prescription. This isn't like a coupon like you would bring to the cash register at a grocery store to, you know, take a couple of bucks off your grocery product, right? This is actually an exchanging of money from the drug manufacturer on behalf of the patient to pay for the ingredient cost of that drug. And so I'll acknowledge that there is some controversy with these cards, and if any of us were to create our ideal healthcare system, drug coupons probably would not be a part of that system. But we don't have an ideal system, right? We have this system where we have sky-high drug prices, and so right now, these cards literally facilitate access to life-saving medications for people, okay? So that's a point I wanted to make. And it is personal to me because I did used to use drug coupons or drug manufacturer copay assistance. And so now we're getting into the meat of my presentation here. What is a copay accumulator? An accumulator is really how a health plan keeps track of the costs that a member pays through co-insurances and co-payments until the member meets their deductible or out-of-pocket maximum. Here you can see my accumulator. This is live as of January, right? This is, you can see I have a $4,000 deductible. January, one trip to the pharmacy, I'm halfway there, I spent $2,000, right? So that was on a pharmaceutical, right? And I'm gonna make that same trip to the pharmacy 11 times, more times this year. I'm gonna make that trip to the pharmacy every month for the rest of my life, right? So high drug prices mean a lot to people, to patients, right? And it's not just me. I know that for me, that's a lot of money, but I know that other people are spending enormous sums of money on their prescriptions too, right? What is a copay accumulator adjustment? It's when a health plan adjusts out or subtracts the value of a drug manufacturer copay assistance from your accumulators. That accumulator I just showed you, right? They subtract the value of the manufacturer's copay assistance. Here's a letter I received from my health plan. Now, it's not Legal Aid's health plan. It's a health plan I get through my spouse. They informed me at the very top there, you can see that the value of drug manufacturer coupons will no longer count towards your deductible or out-of-pocket maximum. And then they tell me in the bottom box there that, well, at first you're going to see the value of that coupon show up in your accumulator. It's going to count for a few days. You might think, wow, look at all this progress I've made towards my deductible. But then they're going to, after a few days, they'll subtract it back out. That's the copay accumulator adjustment. They subtract the value of the coupon after putting it in there in the first place.
I didn't know that.
I didn't either.
That is not helpful.
That is not helpful. No, it's especially not helpful to the patient, right? Who's relying on that assistance to help them to get access to that medication. So here's a graphical representation of what this looks like for a hypothetical patient, John, who takes a $400 per month prescription for which there's $1,200 in annual copay assistance. I'm not going to go through these examples in detail. I'm going to submit my slides to Kiki afterwards, and I would encourage you to take a look at these examples here. But I do want to point out two things on this slide. One is that the best case for the hypothetical patient, John, is that middle scenario where he uses a copay assistance card and the copay assistance card actually counts. It actually helps him to meet his deductible and out-of-pocket maximum costs for the year. It reduces the money he actually takes out of his wallet to $300 from $1,500. And the second thing I wanted to point out here, and it might be a little hard to see on the screen, are all those asterisks next to the amount that the insurance company pays in each of these examples. The asterisk is there because that amount is actually unknown, right? And after rebates and discounts is likely to be much lower than the amounts shown here. It has been shown that in some cases, while patients are paying full list price in their deductible phase of the year, when they go to the pharmacy counter, they're paying full list price, that insurers are sometimes actually paying net $0 and sometimes even making money on the transaction after discounts and rebates. So if we're going to have a system with high drug prices where everybody's after a rebate, where insurers are getting rebates, patients need copay assistance, and they really need that copay assistance to count. This next slide, I'm not going to go through it all again. Just the title of it says it all. Really, it says my position, our position as the HCA, that copay accumulators harm patients. They harm patients by exposing them to large and sometimes unexpected costs, right? I got that letter that told me I was going to be subject to a copay accumulator, and I actually read it, but it looked a little bit like junk mail, right? I think a lot of people might have thrown that letter away. And then after a few months of using their coupon and the value of it was fully redeemed, they would go to the counter and find, oh, now suddenly I have to pay for this drug full cost, and it's the middle of the year, and it's a surprise to them. That person might take out their credit card and take incur medical debt to pay for that prescription, or that person might abandon their prescription at the pharmacy counter, right? And so, well, a lot of times that's what happens. This leads to people interrupting their treatments, and when people interrupt their treatments, their conditions worsen, leading to costlier interventions down the road and a lower quality of life. Finally, in that last box there, undermining patient protections, the Affordable Care Act was passed to protect people with pre-existing health conditions, and copay accumulator adjustment programs undermine those protections. So what is the status of copay accumulators in Vermont? We are not one of the 19 states to have affirmatively banned copay accumulators as of June of 2023. What we do have is the language from Act 131 that's over on the left of the slide there, that any amount paid by a covered person shall be attributed to any deductible and out-of-pocket maximum. And DFR wrote in their Act 131 report last year that, quote, read in the light most favorable to patients, the statutory language suggests that Vermont health plans must apply copayment assistance to patient deductibles, end quote. But as any lawyer would tell you, in the light most favorable to patients is not how courts and regulators frequently interpret the law. So we, the HCA, would encourage, and I think that's why Mike asked me to speak, would encourage this committee to consider perhaps adding an amendment or amending S98 to include affirmative copay accumulator adjustment ban language. We think that doing so would give Vermonters, and specifically Vermonters with chronic illnesses and rare diseases who depend on some of the most expensive drugs that S98 is intended to address on a systemic level, will give those patients some relief right now. And so to that effect, we do have proposed language. They would amend two sections of the Vermont statutes, 18 VSA 9472 and 8 VSA 4089J. The key distinction here, the key difference here is that it adds the language paid by or on behalf of a covered person, and then it goes on to include that includes any third-party payment, financial assistance, discount, coupon, or other reduction in out-of-pocket expenses. And so that's our proposed language. It's just a suggestion for the committee to consider, and that was my presentation.
No, terrific, thank you. As you were speaking, I said, can we make copay adjusters illegal in Vermont? And you answered my question. So.
Yes, well, there we go.
Yeah,
Without even having to have you ask.
Maybe we can.
Yeah.
We'll be, state number 14 if we should do that. But that,
that's our lucky number.
That's
State
right.
number 14.
That is right.
is it?
Yeah, we're the 14th state.
Oh, thank you, Marty. Historical. Okay.
Does anyone have any questions?
I do. I have one question. This is great. Thank you.
You're welcome.
Very good presentation and succinct, clear, and will help some of the folks with really high costs. We worked around that with the report with DFR, but this is super. Thank you. The question really is, so you talk about insurers making making profit off of rebates
Mhm.
that patients might better take advantage of, which patients might take advantage. So how, have you looked into that, and is there language that we could include that would do something in that area?
Well, I think actually, in fact, there's legislation coming up next week in the House Healthcare Committee, H233, and there's
Yeah.
language there that would require rebates to be passed through to consumers at the point of sale. Would also potentially ban spread pricing practices, which, yeah, so there are
Yeah,
solutions
I know,
coming up.
I talked with Mari.
Oh, okay,
So,
great, yeah.
Okay, so that is good, that is happening. So we,
And another concept too of paying pharmacists the actual acquisition cost of the drug.
yes,
Right, instead of an inflated list price. So just trying to strip rebates out of the system altogether, really.
so I'll let Senator Gulick ask her question, but I do have a question regarding that,
Mhm.
try to remember.
Okay,
It's interesting sitting in this committee because we start with companies profiting off products that make people sick, and then we see companies profiting off the sickness anyway, fascinating. I was wondering if we could go back to that graph at the very beginning.
oh, yeah.
Yeah, this one, because so last week when we heard testimony on this bill, we were told that, sort of anecdotally, that countries that, do, cap the prices or have much lower drug prices tend to either ration the pharmaceuticals to their patients or just don't have enough. Is that, I don't know if you know.
I heard that testimony and I don't know. I don't have enough expertise to say whether that's really happening in other countries.
Interesting to know.
Yeah, but
Okay, thank you.
you're welcome, yeah.
Other questions? Go ahead.
Just a comment, having lived through that.
Mm.
Usually that first part of the year when
Yeah.
it's
rough.
usually you got fuel oil
Yeah,
that
I
you
know.
gotta pay for, and
Taxes, yeah.
kids are sick.
Yeah.
It's terrible time.
Mhm.
So
Very expensive. So as you're talking about eliminating rebates, so if we fully eliminated rebates, what thinking have you done regarding our PBMs and how that works for our whole Medicaid population? And
I
that's
have
not a question you can answer.
I have not.
I know, but it's a question.
Mhm.
So is it, which is more beneficial
Mhm.
for our Medicaid patients? We're gonna have to sort that out if we went forward with the categorical elimination.
And I know there's language in H233 that I think
Yeah.
maybe excludes Medicaid. I'm not,
It does exclude, yeah.
yeah,
Okay.
so.
We'll see that, Bill, that's good,
Yeah.
okay. Can I ask one more question?
Yeah.
Okay, so, and then you mentioned something about retail pharmacy pricing.
Mhm.
So talk about that a little bit. You're suggesting that it should be, list price and
Well, the concept is actual acquisition cost.
actual acquisition cost, right?
Yeah. So, and as I'm preparing mentally for the presentation I'm going to do in House Healthcare next week, right? So pharmacies are not paying that list price to obtain the drugs, right? They're paying
Yes.
a lesser amount, right? And then there's a markup. And there are just additionally even markups beyond what the pharmacy is adding on for their own profit, right? So there's all kinds of markups happening, and the idea here is to try to eliminate some of the opacity of that, right? To shine some light on the actual pricing of the drug and to reimburse pharmacies what they're actually paying. With a professional dispensing fee, which is the language in
So
H233.
I'm putting it in the context of a Green Mountain Care Board type advisory body that would be making these decisions, and language that we might want to have that would help the board set some principles and guidelines around actual acquisition pricing and how to preserve the retail pharmacist profit margin and so on. So that's another whole
Yeah,
area.
absolutely, so
And
much
our
to think
pharmacists
about.
have brought that.
Yep.
Okay, Senator Herzog.
No, I just, first of all, thank you. This is a great presentation and, appreciate that if you used yourself as an example, although that must be hard to talk about, but thank you because it was illustrative. But what you're proposing is this ban on copay accumulators in our bill, but the other stuff is already in a different bill.
H333.
Right, so,
And I should be frank, this language is in there too.
okay,
Yeah,
well, we can put it in both places, but,
Right, but the point is that there might be direction that we can give to the Green Mountain Care Board or the advisory board going ahead.
yeah, I was just trying to clarify what we're
Oh.
talking, because we started talking about both bills at the same time, and I'm like, wait, what are we putting?
We
in
haven't
what?
seen it.
Exactly, so I got confused.
and if H233 doesn't get to you, right, I mean, this was why I wanted to bring this concept up to you today, and I appreciate the opportunity to do so.
Yeah, I
Yeah.
think we
So,
should definitely
wait,
have
you
it.
said if it doesn't get to us, is there any chance?
I mean, I don't know, I don't know.
He doesn't get a vote.
Oh, you just did the walkthrough yesterday, okay. Okay, well, we can put everything we want into this bill. Can't we?
We won't need both bills.
Huh?
Then we won't need both bills.
Exactly. Thank you, this
Thank you
is
so much.
terrific.
You're welcome.
Really appreciate it.
All right.
Jen, do you mind coming up for just some discussion on the bill? We have a few minutes before, we have a lot of minutes before 10.
A lot of few
A
minutes.
lot of few minutes is, put
I know.
them all together and you get a lot of minutes. So,
Coming up. That's
What's our-
Come back to.
What's our decision?
we're good? Okay. So we're looking at S98, and so I did reach out to Jane Horvath, who was the person who testified in the beginning when we first took up the bill. And let me step back a little bit. In our last discussion, we had talked about how could we have this go forward and build a prescription drug advisory board, or board that oversees prescription drugs. But our concern was if we did everything all at once, it would be extremely costly and require significant resources at the board. And I think we heard that from the board. So then the question is, what can we do as kind of a transition, a transformation, a ramping up for the board or the advisory board? What can we do that would make it less costly and less staff intensive, but at the same time would take us a step forward in regulating drug pricing? So I reached out to Jane Horvath, and I got really confusing in a minute, Jane Horvath, and she did send some suggestions, which I just got, and I just sent them to Jen, so I have no idea totally what's in that email, but Jen, you had a chance to look it through, but the committee discussion here is do we want to think about putting in place kind of the ramping up process? And if we did, would we put something into statute? And this is a discussion we can have going forward as we move forward on the bill. Would we want to put something into statutes that says to the board, okay, begin slow and then gradually come back to us and keep going without further legislative action? Or do we put something in place that then the next step would require further legislative action? And some of it will depend on how far along we can get in our thinking about the bill. But I just wanted to share that as kind of the way we might want to look at this so we can avoid the collision course here and in appropriations and at the Green Mountain Care Board. They can't ramp up everything, boom, it all happen. So that's the thinking. And one of the suggestions that was made I think we mentioned it last time, was it starting with the Medicare, what Medicare drugs are now being considered between federal government and manufacturers, and beginning with those drugs and looking, and then secondly, looking at drugs that other states are working with. So maybe the Colorado or the Maryland or whatever, five drugs that they're looking at, to send that initial direction. So there, that's what I've been thinking about, that we could maybe
Is this just
consider.
like the legislating the low hanging fruit strategy?
You got it. You got it. There it is. Dates and oranges. So, but it's a way to get things ramped up, knowing that there are a lot of issues that would have to be resolved at the Green Mountain Care Board, and I'm looking right at the Green Mountain Care Board. That has the board had any further discussion? Julia, do you want to make a comment, or
Yeah, I don't have a ton of updates. I've since last.
for the record? I asked you a question.
Yeah, for the record, Julia Wolf of the Green Mountain Care Board. We've been continuing to reach out to other states. We talked to Oregon yesterday and learned a lot about the research type work that they're doing and the level of analytics that it's taking. So I don't think that the conclusions are that different from last week, but we're continuing to try and look into and pick their brains about if they could do a low hanging fruit option, what might that look like if they weren't as robust as they are. So we're trying to ask those questions.
Okay, so we might want to, we'll link you into the conversation, and as Jen starts looking at possible language, we'll make sure that anything that we have, we can share around, so it saves you the phone call, maybe, I don't know. Okay, comments committee. So now it's the low hanging fruit, I like that. Low hanging fruit.
Yes.
And then we're gonna go for the high hanging fruit, but do we wanna go for the low hanging fruit and leave a pathway in statute that goes right to the high hanging fruit? Or do we wanna have to have more legislation to take the next step?
No, I think we want to, I personally, I think we want to say, start with the low hanging fruit, and then once you're done, go to
Get
the
your
next
feet on the
level.
ground, get a ladder.
Without having to have more legislation, because I think that would just be cumbersome. I trust them to set it
Well,
up.
regardless of what we do, whatever the board is, comes back with appropriations requests, that is kind of the legislative.
Exactly,
Yeah.
exactly.
Okay, does anybody disagree with that concept at this point? We can always come back and read it.
My only thoughts are that, we're creating a board that we are entrusting with this topic. I trust them to hit the low hanging fruit first. I mean, they're bright. We're gonna create a board of very bright and experienced people that's exactly where they're gonna go. I don't think we need to legislate that. I think they'll figure that out. They've already figured it out.
Well, let's look and see what's been recommended, because what we don't want to have, I hear what you're saying. Consider that, and very much so, and I think the board has the savvy to do that. However, if we don't have that in there as a first step, then we might be seeing a lot of planning and testing and thinking going on before anything happens. So we want to see action, so we can legislate some action to take place, and then they can ponder on the building the ladder. LADDER. Yeah, okay. Go ahead.
So first, my understanding is we're gonna have to legislate Green Mountain Care Board's ability to do this, right?
Yes,
So if we can put language in the legislation that says we're gonna start out with the low hanging fruit, and then give them some authority to go someplace without more legislation, I'd be in favor of that.
I'm for it.
Okay.
Yeah, no, I think I'm for it. But we gotta do it right. I mean, it's not like it's gonna be simple. First Senator Gould.
Thank you, thank you. Just to tag on to Senator Williams's comment, had we mentioned before that we might need to add some capacity to Green Mountain Care Board to be able to do this work? Okay.
Yeah, that's why I say the low-hanging fruit will be less costly in terms of any kind of
Right.
appropriations or resources recommendation.
Got it.
And, you know, when they start doing this, will depend on when that's needed.
Okay.
Senator Hurry, go ahead.
That's okay. I'm fine. I mean, I was just gonna say that, but it doesn't matter. Forget.
Okay.
Yeah,
What-
I think we should move forward and see what we want to put in the bill. I
Yeah.
agree, with Senator Weeks that they're a smart group and they'll go to the low hanging fruit. We might want to put a few like benchmarks in or something, I don't know, but
Yeah,
let's
exactly.
talk about the
Yeah.
language, that's the most
Start
important thing.
walking up the stairs.
Yeah,
Yeah, that's good. Okay. So while you're sitting there, is there anything that we need to hear from Ledge Council? She doesn't look.
Jennifer Harvey?
Did you just
Not smile.
So I have the language from Jane Horvath, or at least the concepts from her. Is that what you're looking to have in a new language, or I'm not sure how to operationalize low hanging?
Let's do two things with this. Yeah, let's operationalize that. So let's put some, I haven't looked at it. I don't
do
think
we
anybody's
have the
got-
language from
No, it's
her?
just an
It's
email I
just
just
an
got.
email with some sort of,
And wait, who is she again? I'm sorry.
She's the consultant who who did work with Nashville, and now she is working, I think, independently.
yeah,
as
she testified on the first day when we did this walkthrough, and she's been focusing a lot, Jane Horvath, on
Right.
prescription drug affordability with us,
She got
with Nashville, with others.
I worked with her when we did our importation,
Importation.
right, and at the Nashville meeting and stuff. So, but, did you want to make a comment? Okay, can I operationalize first? Let me do that, and then it'll be great. So I'm thinking that why don't we get, whether it's full language, and, you know, that takes a long time to get the full language. Why don't we get, kind of some bullet points of what is being suggested here, and I'll look through it, and maybe we can get that sorted out, and then, we've already talked about the ramping up piece, but, so we'll sort out the bullets that she has sent to us and suggestions, and the suggestions were based on some of the comments that I've just made here around the table, about ramp up, low hanging fruit, et cetera. We'll look at that and we'll compare that with what we currently have in the bill and see what improvements we can make to the bill. Does that make sense for you?
I think so. So next step for me is just to distill her thoughts into some bullets.
Yes, that's it. If it seems that there's something that
Can you
is
create a
easy to
Venn
flesh out, fine. If it's not, I didn't hear that.
Sounds like we have consensus anyway.
Yeah, no, I think this will work. And then next time we come back to the bill, I forgot whether it's when it is, but next time we come back to it, we'll have something a little more tangible to work with, and as we'll take more testimony. I know there are some, what Charles Becker just presented is, I think, reassuring to some of the people I'm hearing from about the high-cost drugs, the people that have high out-of-pocket or co-pays. So, yeah. All right. Is that a plan? Is everybody okay with that? All right. Let's do it. Thank you. This is good. That was like instant. We just got the email and then bam. But we do have a plan here. I think there's so much interest in having this go forward that we need to make it work properly. And Julia's over there ready for action. We'll share the bullets with you, you know, as we go through this. Make sure you're here when we do SNU. And anytime you want to testify, let us know.
I'd like to express, if I can, one concern which came up during testimony last week
Okay.
from the pharmacist. Just take a second. I'm not gonna make it,
No, it's fine.
it's just an observation. The tension between the manufacturer and the distributor who gets the essentially remaining profit if we lower the ceiling, that's gonna be a challenge.
Right, and that's what, Mr. Becker was talking about a little bit. So there is that concern and how to ensure that our retail pharmacists remain whole because they do more than dispense drugs.
And there is a lot of that in 233, assuming that comes here, the PBM bill,
Okay,
that the House is working
how
on.
much we have to do, well, we don't
Well,
want
it's
to
looking
miss
at, right, it's looking at pharmacists and reimbursements to pharmacists and,
it. So is it that we would direct the board, the new board to be, cognizant of or to work on that? Or is it, they're bringing us some specific language on that? Well,
yeah, I think you're gonna have to,
sort it out.
have to look at both of them as you move along and decide
Okay.
where the direction should go.
Each 233?
H two three three. 233.
Oh, it is
233.
Thank you. Your ears are better than mine.
I got hearing aids.
Yeah. Oh.
And they just started yesterday that they're planning on doing a fair amount of it on it next week.
Okay, well, we'll just look at that individually, see what's in. All right, anything else? So we're gonna take a little break. And so, thank you. This has been productive. Thanks, Jen.
Sure.